Thank you so much. Hopefully you've been finding the symposium very interesting and insightful so far. So I'm thrilled to pass it on now to our next session. So Annie, it's all yours.
All right, we're going to take it away. All right, thank you everybody for coming back from that short break. We appreciate it, but we have so many wonderful things to talk about. So we are the transition panel of the transition topic today. So just to do a little context setting and maybe a little empathy work, we're talking about the teen years. So for some of us, that was a little while ago. So I'm just going to remind us what happens in the teen years. We're talking about pretty much middle school and high school. Some of us are parenting people that age right now. And we're lucky to have some people on this panel who are that age. And so that's the time period where you're hitting puberty, you're figuring out who you are, you're starting to figure out who you want to be in the world is starting to feel maybe limiting, and you're trying to figure out how to break through those barriers. The world is supposed to be getting bigger for you, although maybe culturally and socially it may not be feeling that way. This age range actually is now starting at age 13, is a generation of people, are actually starting at the upper age limit, who are now post-ACA. So I just want people in this room to think about that for a second. Some of us were a part of that. That this is a group that will not have known what it was like to be in the healthcare system before the ACA. This is a group who, many of whom were born after the first batch of conditions were added to the newborn screening panel. So this is what we're talking about as far as this age range. And so I'm really thrilled to have a panel of experts here with us today to talk through what the science of patient engagement looks like from the first and foremost, that social aspect, clinically and clinical care. We're going to talk a little bit about registry participation and clinical trial participation. But most of all, we're going to talk about how to honor the individual as a patient moving through that ecosystem during that age period. And then we're going to talk a little bit about preparing for that transition into adulthood, which will be the handoff to the next panel. So I'm going to introduce our panelists today. So first of all, I'm Annie Kennedy, and I'm with the Every Life Foundation for Rare Diseases. And I've had the privilege of getting to work in this transition space throughout my career, working on transition policy, but also really importantly, getting to work with young adults and teen groups in the neuromuscular and the rare disease space. So that's been really wonderful. And very on point for this panel, I'm the mother of a 13-year-old who's been texting me the whole time I've been sitting here because he lost his AirPods somewhere at school today. So you could all just offer up some hope for Jacqueline Kennedy when he gets picked up from school that those have been located. All right, so first I'm going to introduce to my left Dr. Jonathan Shepard, who I may actually be calling later for an appointment, who's the Chief Clinical Officer of the DC Department of Behavioral Health and a board-certified child, adolescent, and adult psychiatrist who works with children and adults as well as their families. Dr. Shepard specializes in treating attention deficit hyperactivity disorder, ADHD, mood disorders, anxiety disorders, obsessive compulsive disorders, and post-traumatic stress disorders. His skills include conducting diagnostic assessments, developing multimodal treatment options, and medication management. His mission is to improve the well-being and mental health outcomes of children and adults by providing evidence-based, culturally responsive, and trauma-informed care. Thank you so much for being here with us. And he just got off a train from New York literally moments ago. So thank you so much for being here with us. Next, we have Elsa Kendall. Elsa is a patient advocate for hemophilia, a rare bleeding disorder, and has nearly a decade of experience in advocacy. Elsa is passionate about improving health equity in research, diagnosis, and care. In 2024, she founded, I'm just going to read that one more time. In 2024, Elsa founded the Red Ink Project, a nonprofit dedicated to rewriting the narratives of women and girls with bleeding disorders through education and raising awareness about issues uniquely affecting women and girls with bleeding disorders, including newborn screening protocols, unequal representation in research, and the period tax. I'd also like to mention that next month, in less than 30 days, Elsa will be graduating from high school. So we should just congratulate Elsa.
Thank you.
Congratulations.
And I think her school should just automatically make her valedictorian for serving on this panel today. And then we have Teresa Jackson, who's the mother of an amazing 13-year-old son, Akil, who is seated right here in front of us and is dying that I just acknowledged him, who was diagnosed with hydrocephalus at 2 months old. Teresa is a volunteer with the Hydrocephalus Association and has over 10 years of nonprofit fundraising experience. She's currently studying for a degree in English at the University of Maryland's Global Campus with aspirations of advancing to law school. So welcome to our amazing panel today. Thank you for being here. So first, I'd like to start with Elsa, if we could, as our expert teen high schooler on the panel. Could you first talk a little bit about how you became involved in patient engagement, and maybe just even for frame of reference, why this topic today matters to you?
Absolutely. Thank you for that great introduction, Annie. And it's great to see you all here today as well. So I am relatively new to the patient engagement area. As a teen, there is a limited number of years I could have dedicated to this area. I would also add that. However, my journey to this point really began just over a decade ago when, at 6 years old, I was diagnosed with hemophilia, a rare bleeding disorder. Those first few years post-diagnosis were really spent by my family and me learning the basics of my disorder and how it affected me. And because it's, in my case, a hereditary disorder, learning how that would go on to affect me later in life. However, at age 9, I had my first opportunity to advocate in front of Congress and the Virginia General Assembly. And that's really when my personal advocacy journey began. As I learned more about advocacy itself and how to educate others on my condition, but whether it was in front of Congress or at school, as something as simple as telling my teacher that I had a cut or a scrape or a bruise and that needed special treatment. I began thinking about how I was being treated at the doctor's office, as well as kind of as a kid with a rare disease. And at that point, I had already kind of known and learned, whether it was my parents telling me or kind of just implied at the doctor's office, that as a young woman with an X-linked genetic condition, I was extra rare, which provided its own set of kind of rules and expectations for how my diagnosis would affect me. And as I began hearing more patient stories and refining how to tell my own patient story, I kind of began examining how conversations around women and girls with bleeding disorders were evolving. In that slightly over a decade since my diagnosis, there has been a lot of progress. However, there still are not really dedicated permanent spaces for sustainable patient engagement for women and girls with bleeding disorders. And so that's what inspired me to found the Reading Project, my own nonprofit, and really get invested in this space, especially just because the teen voice, I think, is something that has been underheard up until now, and I think we're finally have the tools, whether digitally or through opportunities like this, to start making a difference.
Absolutely. I failed to acknowledge your mother, who's here with you, who hopefully will be teaching parenting courses out in the lobby later, because you are amazing. So congratulations on everything you've done. So I'm going to now add, and we'll went back to some of the themes that you've introduced here, because you've introduced a lot of really important themes. But one I want to follow the thread on is you talked a little bit about finding your voice as a patient advocate, and you talked about some of that came from your parents teaching you, and some of that came from providers teaching you. So I'm going to ask maybe Teresa to go next. And Teresa, if you could talk a little bit about, as a parent, why this topic really matters to you, and then as a parent of a young child who was diagnosed with a rare disease, or with hydrocephalus, can you talk about how, as a parent, you helped your child find their voice and how you found your voice in that ecosystem?
Well, yes, thank you. Being diagnosed at 2 months old and having his brain surgery at 3 months old, it was just all really a shock. And just finding information, just knowing what was going on, trying to find what was the cause, what was the reason, or what's going to happen next, where are we going, or just how is his health going to, is it going to decline, or what's going to happen. And that was a big reason for me just attending a lot of meetings and just trying to find information. And so now we're at the point where Akil is 13. He hasn't had any shunt revisions. And
That's good.
thank you. But at this age, and I've been learning from the Hydrocephalus Association, you know, we are transitioning, and I know that, but as we do, he's going to have to start speaking for himself. And the doctors, talking to the doctors and knowing about his own medical condition and being able to handle appointments eventually once he gets older. And where are we going to go as far as the, you know, what's the next stage, what doctor will we go to, or, you know, things like that. So that's why this is really important for me, just to know what's being done to help him as he transitions.
So let's follow that thread. So Dr. Shepard, can you maybe first talk about with this stage in life, and since you specialize in working with patients with this stage, how you work with families, both maybe as parents and young people together, and then maybe how you work with families uniquely, and were there opportunities to help the young people find their own voice, and then work with them to maybe learn how to articulate their needs to their parents individually?
Yes, so good afternoon, everyone. And it's good to be here. And just literally did get off the train for the American Psychiatric Association annual meeting, which was held in New York City, which is a wonderful meeting. But I'm glad to be here. So you all are special because I've made sure that I was here on time for a little bit. The train was a little bit delayed. But I wanted to be here because of this particular topic and how important it is. And that particular question really lends to a couple of answers that I already had prepared. But you know, when I think about what parents need to remember about, and first of all, I do want to do this. I want to celebrate all the mothers who are in the house because it is Mother's Day weekend coming up. So let me do that. I think I'm a smart individual to do that. I wouldn't be here if it wasn't for a mother. And thank you, mothers, because teenagers are they are individuals who, I tell you, they are just special people. They are. And you have to remember that because the adolescent brain has not changed. You have to remember that even with the various technologies and the different innovations that are happening, the maturation of the adolescent brain has not, and I don't believe will ever change. It still will proceed along a certain chronological timeline. And the brain does not mature until the age of 26. So you have to keep that in mind. So I know parents out there, if you have a 13-year-old who just lost their AirPods and things like that, they drive you crazy. That's because one of the major things that happen, there's 4 things that happen with them. I did write this down, and I am going to answer the question, but you have to have the foundation.
No, this is great. Keep going. This is
right.
really good for those of us who have to go home to our kids.
And so maybe I'll get a chance to go and dive a little bit to each of the 4, but number 1 is impulsivity. Impulsivity is part of the adolescent brain. So if your child is impulsive, stop trying to punish them for being impulsive. It is part of the adolescent brain. Number 2 is risk-taking. Man, that's so quiet. Because it is part of the adolescent brain. Number 3 is sensation-seeking peaks. Sensation-seeking behaviors. And for those who are males, it peaks at age 19. So it actually peaks a little bit later. For women or young girls, it actually peaks at 16. So, you know, especially for males, you wonder, well, how come you just can't get over this? At age 19, it actually peaks. And then number 4 is that in the adolescent brain, peers are greater than their parents. You will never outdo their peers. So you just have to learn how to deal with that, be able to manage that. So these are 4 important things. We may get a chance to talk a little bit about each of those 4, but I just want to set that foundation to understand the adolescent brain. We do understand it, even though you may not understand your adolescent or your teenager, but we do actually understand it. And so in recognizing that, you have to make sure that you're prepared and apt to remember those important milestones. So I'll stop right there with that.
So, well, let me go back. So first of all, we're all taking copious notes, and I think we'll all be enjoying a support group later. Thank you. I also want that to be a reminder to anybody who thinks about they want to get married earlier than 26. That was really good guidance. I like putting that out there. But maybe go back to
Yes.
just a question about how do you as a provider, and then I'll ask the question from our other viewpoints here, think about working with people within this age range, because as a mom, I have a son who goes to clinical providers, and I really love when the provider provides him with an opportunity to be in the room alone with the provider. But as a mom, I'm going to be honest, I have the inclination to try and listen at the door, not because I necessarily need to know what's happening, because I'm also afraid he may not know all the answers that need to be provided. So can you talk about, from a provider's perspective,
Absolutely.
how you're navigating that?
So number one, thank you, is stressing communication. Communication is huge. So when I'm meeting with adolescents, teenagers in my office, for whatever reason it may be, I typically have the parents or guardians who brought that person there to come into the office with me. And then depending on their comfortability, they may stay in there, or we may have some time alone. It just really depends on where people are at, because you're absolutely right. You can have a teenager come in there and they'll fill up your time for 60 minutes and have steered you down the wrong road. And then you come to find out all these other things that are there because you didn't get a chance to talk with the parents. So I stress communication because, number 2, conflict resolution. I try to mirror what should be happening even within my office, even in the first time around, of how to be able to talk to each other. Even when the child or the teenager and the parent do not agree, I try even that first session to see how can we resolve some minor conflicts, and it helps them to be able to be open to one another. So that actually is very important. And then the last thing is I work with the parents, and this is really major, and a lot of people don't like to talk about this. Many times the parents have guilt about why they had to bring the child there, and guilt about, well, I didn't want to raise my child like my parents did. So I just didn't want to do the same type of things that were done to me. And so a lot of that I actually have to work with and resolve. One of the things I really find out, I'm going to stop here, is that when children present to me with anxiety, which is the most common mental health disorder in this country, most of them are experiencing it because their parents are experiencing anxiety. And it's almost without fail that I have to really treat the parents and work with the parents. I mean, Dr. Shepherd, I'm not here for you. You know, it's the child got the problem. I said, I know, but we got to help you too. Because if we don't help you too, then we don't get a chance to really help the teenager or the adolescent.
Just gonna let that sit in the room for a second. So maybe I'll ask the question to Teresa, and then we'll come to Elsa. Can you talk a little bit about, for your experiences now, I know Akil is 13, so you might be at the early end of this, but maybe not. To what degree are you at a stage where providers are having appointments together, or where you're having opportunities to have some separate time in your appointments?
We're not there just yet as far as being separate, but providers are, when we are in the room, they're speaking directly to him.
Okay.
And it's transitioned, I've noticed that way, to where initially it was, Mom, how's everything going? Akil, how are you? But now, I'm acknowledged, it's not in a disrespectful way or anything, but the focus is Akil. And getting him to respond about how he's feeling, how he's doing. And I like that. Just to be honest, I don't know that I'm ready for the separate just yet. But can I just say one more thing?
Yeah, absolutely.
When I mentioned to know what is being done to help him to transition. More so, what should I be doing to help him? Or how can I be even engaged with providers more so that when it's his turn to speak on his own behalf, he'll be able to. Or when he needs to inquire about his condition or ask the questions that I'm asking of the doctors, like how can I get him or help to prepare him for that?
That's great. That's actually the perfect segue to Elsa. So can you talk about your experience and how that transition's gone? And you may even have guidance, actually, to answer Teresa's question.
Yeah, so I feel very lucky in this realm because my parents started preparing me from a very young age to be able to answer questions from anyone about my diagnosis, whether that was in a school setting, obviously advocacy training for Congress, or to be in a medical setting. And I would say that my specialists have also been really great, and I know this is not the experience for everyone, but certainly by the time I was 13, 14, to start very much talking directly to me so that even though it might not necessarily be necessary or the absolute, I got comfortable with that experience and was able to articulate whatever my symptoms were and feel included in the conversation. So I feel like my experience has been kind of extraordinarily lucky in that regard. I know that's not everyone's experience. So I think that's also helping to kind of define and to show me as a patient and as a teenager the transition of, what are my parents doing 4 years ago, what are they doing now for me, and what will they be doing going forward, because that's it's a continuous segue. Your parents are always involved in your life and always involved, thankfully, in my medical things. So just what does that look like? And I think people have been very clear with me on what that looks like, so I've been fortunate.
That's excellent. That's great. I'm going to switch gears and just start talking about research and clinical research. But before I do, I just wanted to know, Dr. Shepard, do you have any guidance for, we have a mixed room of clinicians and patient advocates and researchers and individuals who are a part of the patient community here. Do you have any recommendations for people as they sort of navigate creating good practices for thinking about how to engage with the patient community in this teen setting around clinical care?
Absolutely, and really I'm just going to echo what the other two panelists have said. They really have given you a practical look from the, I guess from the other side of where I would be sitting as to what to expect from your provider. It's so interesting when a person comes into my office, a family, and they have a list of expectations. That really is helpful for me. And then the provider has to be open to listen to the expectations of the family as they're coming in. So it has to be a two-way street. There's too many of my colleagues that I have met, and again, I'm not trying to throw anybody under the bus, but sometimes they just come in thinking they already know what's best for the family. But one of the things that I really have realized, and it really took hold after the pandemic, well, actually during the pandemic and after the pandemic, is really for me just to kind of sit my intelligence somewhere down and listen to what the people have to say. And when you listen to what people have to say, many times they will answer the questions that you need to have answered. I have found that over and over again, and many people will say, well, how did you know this? I said, well, actually, you told me this, and I just allowed for you to talk. And so one of the things that I've found as a provider, you have to be in a space where you're able to allow people to be themselves, to talk. Teenagers, it's going to take them some time to be able to open up to you. And they want to make sure that you appear approachable, that you're flexible. I let them know if there's a question that if you don't want to answer it, then that's okay. We'll come back to it. But I don't stick around. And I've seen some of my colleagues do it, try to ram it down their throat. Well, I need to know this now. I need to know who touched you. No, let's take some time to get to know each other. And one of the things I've also is I've been able to share some personal stories, that are appropriate with the teenagers. And I found that has even been able to open up to let them see me as a real person. I want the family to know that I'm not there to just be the doctor. I'm there to be an ally. So I remind people, when you are a good provider, and there are good providers, but when you're extraordinary good, that's when people really see you as an ally, as a person who they can come to, who they can trust. Because there's some doctors, I have some, even on my team, I say, okay, I can trust you, but I can't tell you everything. And isn't that a shame as a physician that I have to say that? And you all know I'm right on that, because there's sometimes people don't tell you everything that they need to know. But when you are able to take some of those skills and be able to say, I want to be an ally, I want to work with this family, I want to figure out how do we get that person and get that situation solved and that need met, then I see, even within the clinical research area, where you have families who will come in who will want to participate in your research. It's very difficult to do when you're looking for adolescents. But one of the major ways I found out for people to be able to participate in those studies is they feel like they can trust you and that you're there to assist them and be an ally.
Beautiful segue. So let's talk a little bit about participating in studies. I would just be interested to what degree either Elsa or Teresa Akils had an opportunity to participate in clinical trials or clinical research, or has that been something that you've talked about as a family? And I guess my second question to wend into that is, even in considering that, have there even been resources or tools or things that would inform the decision-making that you as a family would need to be considering? So whichever one of you want to take that first.
I'll go.
Sure.
We haven't been in doing any clinical trials or anything like that, and I'm not sure if that's being done. Okay, it's not being done with people with hydrocephalus, is what I'm just learning.
We're here to learn. Are there registries that you've been able to participate in yet?
Yes. There are registries, but that I've been participating in, not just yet. Okay, so this is an area that's developing with hydrocephalus, is what it sounded like.
This is like when you get to phone a friend in a game show.
Like that.
Okay. No, but that's great.
Okay. Yeah, so.
Yes. So before I continue with my own personal experience, I would just say that women in bleeding disorders research have been historically underrepresented and underinvolved. That is changing slightly, but just to give a little bit of context of why it's important to include women in bleeding disorders research, I tried a new medicine this past November. It was new, first time, really excited about it. Getting it in went well. The next day, I ended up in the ER in excruciating pain. And at the time, we did not know if it was caused by the new medication or not. We had no way to know because there was only one woman involved in the clinical trial.
Wow.
And I mean, that is the reaction of everyone we talked to at the ER. They were shocked. To us, this is not unusual necessarily, however. Thankfully, or unthankfully, later phenomena proved that it was not that medication. However, we had no way of knowing that at the time. So that is really the importance of inclusivity in research. And thankfully, I've had my genome mapped, and I am a part of a bleeding disorders patient registry. However, research opportunities need to be more open, and we need to be looking at how to accommodate women, teens. I think it was Ms. West who highlighted that, having trials on a Saturday instead of a Tuesday, things like that, and really those tangible things, offering school credit. Whatever it is to make it more accessible to teens, there are some really kind of small, tangible things that can be done. Doing things during the summer while on school break. That's really important as we start to shift the conversation more towards teens and women in this environment.
Yeah, most definitely. I'm reminded of two other examples. Those are great examples that I would add. One is that thinking about registries, I remember a community I was working with had a really advanced patient registry that added a new module for the young adults to have their own responses, which was terrific. But we encountered two issues. One, the young adults wanted it as an app, shocker, because they didn't want to go in and do a module on a laptop. But that really forced a new development of an app for the entire registry, which was terrific. But then there wasn't an easy way to connect the data being entered by the parent or the caregiver and the data being entered by the individual actually living with the condition. And so that's something we should probably be thinking about earlier when we design our registries and our data elements.
I just want to say something very quickly,
Yeah.
too. And so thank you for that. It's such a mature answer. I just need to add on to that is that we need to make sure our marginalized communities are a part of that registry. Because she's talked about hemophilia, but we talk about sickle cell anemia and other things that we know Black people deal with. And we know that when people are not a part of the studies, then they will be treated differently, or they're provided medicines that may not work properly for their particular system. And so we must remember that adolescents are not little human beings or little adults. I'll say that again. Adolescents, teenagers are not little adults. And how a Caucasian person may respond to a medication is not the same way as an African-American person. That's been proven over and over and over again. And so that's why we have to be very intentional on these particular efforts. And so thank you for your answer.
That's great. And then just the other thing, and I would love anyone's thoughts about that, is as we think about new technology, also we need to be thinking about, we talked about AI in the last panel was something that was talked about. Wearables is something that gets talked about, adding to digital health tools, which is wonderful. But again, I think we're adding probably to the discrepancies and the inequities in the health system potentially. But this is where I think making sure when we talk about the patient-centeredness and talking to patients about their preferences, it's not just okay to say, well, we had one focus group of the patient community, but to not have considered the age subpopulations within that community. So in other examples, there was a wearable being created for a disease-specific community, and they talked to parents within the community about the design of the wearable, but then once they got further down the design of the wearable, the teens who would be expected to wear it thought it looked like a tracking device from a prison, and they didn't want an ankle bracelet on their ankle that they'd have to wear to school.
Oh, wow.
But that hadn't been considered by the caregivers who had thought about the wearable as being a really efficient way to track steps throughout the day. So thinking about the teens and young adults specifically as your target group that you need to be talking to in a meaningful way. So maybe we're gonna open the mics up. This is probably a good time to do that. Where are we? 5 minutes. Okay, so we're gonna keep talking, but if people have questions, please come to a mic, and if you're at this mic, make some noise, because it's hard for me to see over my shoulder. But we'd love for you to come if you have a question. And, oh, we have a question. Great. Don't be shy.
Dr. Shepard, I love the point that you made about anxiety, and I want to mention in this, for many of us with chronic and rare diseases, medical anxiety is a huge factor in how we see the healthcare system. Mm-hmm. What strategies do psychiatrists use to deal with that? What strategies can we as patients use to deal with that? Any thoughts would be great. Thank you.
Absolutely. So we normalize anxiety. Everyone in here gets anxious. And we have to understand there's a difference between distress and disorder. So when I speak, I talk a lot about what distress is and what disorder is. Everyone in here is distressed, all right? Everybody get distressed, all right, whether or not you admit it. But everybody don't have a disorder. A disorder means that you're unable to function properly. So when your anxiety gets to a point to where you cannot function, for adolescents, mean you can't go to school, you're unable to operate with your peers, all those other things I mentioned right over there earlier, that's part of the adolescent brain. So what we try to do, we try to normalize anxiety, that it's okay to be anxious, but it's not okay to be dysfunctional and then operate dysfunctional.
Thank you.
That was a great question. All right, excellent.
So question to Dr. Shepard. Obviously, you're a psychologist. Is that
Psychiatrist.
Psychiatrist, sorry.
No problem.
So I'm from the American Institute for Cancer Research. I'm a childhood cancer survivor. And clearly in a psychiatric context, that getting to know someone is very important. That's part of, the patient is already familiar with the problem they have. In cancer, that first interaction with an oncologist or the surgeon is completely disorienting. Particularly when you're a child, but it's actually throughout life course. So there isn't that opportunity to take time to get to know what's important to that patient. You know, oncologists are 15 minutes if you're lucky to see the patient.
Yeah.
So, I mean, fortunately there is nurse navigation. I think that's it's not available everywhere. Across the panel and even in the room, how do we address that? How do we get the patient perspective, seeing the patient as as the center of the treatment rather than, I think it's even more likely when it's if you're like a cookie cutter cancer, you've got ER positive breast cancer, you're getting X, Y, Z. Rare cancers, there tends to be more discussion and the patient's more involved. But I just think it's very different in the different disease entities. And there are shortages of oncologists and so just.
We got you. I'm gonna let my panelists answer first, and I'll come behind them
Okay.
if they want to answer.
Thank you.
Just, I want to be sure I understood the question, which was how to, instead of a cookie cutter approach, how to specialize. I think it will depend on each individual. Like, just for instance, with Akil, when he was small, we had a doctor's appointment where he didn't want to be touched at a physical. And I was, sit down, do this, do that. And the doctor said, it's okay. And Akil got under the table and played with his cards. And the doctor got under there too. And I was in shock. I was like, was I supposed to, make him, force him? Right. But she said, it's okay. That's and she did his exam or what she needed to do there. Right. And so maybe that is an approach, like you meet the person where they are as best you can.
Yep. Mm-hmm. Whole person care. Thank you. That was an excellent example. Better than one I could have given. Whole person care is where we have to be at. And you must demand it. I already said it earlier. When you go in to see your providers, you should go in there prepared. So many people come in to see their physicians and they're unprepared. And I don't get it. And again, I'm not trying to go off on anybody, but people are scared. People are very anxious, especially when dealing with cancer. I have a strong family of prostate cancer in my family. I have just generations who've died from prostate cancer. So I understand what that is, because I've watched people in my family die from cancer. It's anxiety provoking. So maybe bringing somebody with you who can help you and writing down what you want to have. And then, oncology teams, they do have psychiatrists and other mental health professionals who are part of that particular team. Make sure you go to an oncologist who has that person. They may not be able to do, because these insurance companies, they will make sure that you only see them for 15 minutes, or they won't pay you for other, I know that that's true. But you want to make sure that they have a whole person care team, so that way you can hopefully get some of those anxieties dealt with.
Excellent. Do we have time for more questions? You're good? Okay, we can take one more question right there.
Thank you. Yep. This question is mainly for Elsa, but also for you guys as well. I find your story very inspiring, getting involved so young. I love it. I want other young patient advocates to get involved as well. My teenage years are not too far behind me, and I remember what it was like to be an advocate and a teenager and being in high school and having all this passion and energy and drive to get something done, right? But I always found it difficult to engage both myself and my peers for a long period of time and to stay involved. Like you mentioned, it's so important that younger people are involved in the process. How do you look at engaging people our age and younger in advocacy in general, and how do you get people to stick with it?
Thank you.
That's a great question, and one I would say I don't have a definitive answer to, because this is a struggle I've seen many organizations go through, and in forming my own nonprofit, that one that's kind of at the forefront of my mind. I was lucky enough to have patient organizations I was involved with at that young age, really prioritizing kids, getting up and talking about their experience and telling their story. However, I think it comes down to kind of considering the teenage experience of, how many extracurriculars do kids have? What does their schedule look like on a weekly basis? Trying to have events as much as possible on weekends, staying connected through email chats, and that's where technology, I think, really does come in handy, of, having, whether it's a Google chat or, an hour-long Google Meet once a month. In terms of sustained involvement, I think in that context, it does become important to minimize the daily impact of that. For example, I'm part of a program that's for young people ages 16 to 30, and you have to come to 3 meetings a year, and it's an hour once a month. So I think figuring out ways to make it manageable, looking at your own life and experience and what would have worked for you at that point and what works for you now, I think is a great starting point.
Great question. All right, well, this has been a really fun panel. I feel like we could do it all day, and also it would make me a better parent if we did it all day. But I just want to thank the panelists for being here with us and for your really wonderful guidance, and for all of you for investing in the science of patient engagement. So thank you.